Good morning, good afternoon, good evening. Warm welcome to today's ISQua webinar on improving safety in mental health settings. This webinar will explore the concept of harm, types of harm, and describe how a national program in Scotland approaches this, and share the results to date in terms of engagement with services and service users, as well as qualitative and quantitative data. We are delighted to welcome today's presenter, Dr. David Hall, consultant psychiatrist who is the clinical director and deputy medical director of Mid Park Hospital in Dumfries. He is also the national clinical lead for the Scottish Patient Safety Programme for Mental Health. A native of West Scotland, David has practiced as a consultant psychiatrist in Dumfries for over 20 years with significant roles in service redesign and medical management over that period. He has led the redesign of the clinical service, including the development of one of the first home treatment services in rural settings in the UK. He has a background in medical education, research, in particular with service innovation and redesign. Just to remind you that today's presentation will take approximately 45 minutes, and we will leave 15 minutes at the end for any questions that you may have. Please type your questions into the chat or question box provided, and they will be posed to Dr. Hall at the end of his session. Please note that we will be using a number of polls during Dr. Hall's presentation and would really appreciate your active participation. Now, enjoy the presentation, and over to you, Dr. Hall.
Hello, good morning, good afternoon, good evening. It really is a privilege to be speaking to you all. I know it's a very international audience, and thanks for that very kind both invitation and introduction. I'm going to speak to you about something which we're very proud of here in Scotland. And an apology in advance, I am Scottish and I do speak too fast sometimes, so hopefully you can understand my Scottish version of English. As I say, it's a great privilege to be here, and I'm speaking really on behalf of a team of people across Scotland who've been doing this work. I guess one of the fundamental underlying principles of the kind of work we've been doing is that essentially if things are going to improve, they have to change. And mental health, like many other systems or areas of practice, there are many things that we've always done things this way. It therefore shouldn't surprise us that we always get the same kind of results, or indeed that the same kind of problems occur. Anyone who's looked at a serious critical incident, such as a suicide, will identify many things in common that seems to go wrong each time. So the starting tenet of the patient safety programme in mental health, same as other programmes trying to reduce harm in other areas, is that we need to challenge what we do and challenge the assumptions that we make about what is inevitable in terms of our practice. So yeah, international audience, I'm sure you don't need a reminder of where Scotland is, but that's us with a big arrow. And I'm speaking to you from Edinburgh with one or two colleagues here to help me and keep me right. And I'll start with an example, I guess, to illustrate how things can change, how culture can change and be challenged from Formula One racing. Many of you will recognise Ayrton Senna, and he died on the 1st of May 1994. And although safety in Formula One racing had been improving, that event, that terrible weekend, there was another driver, Roland Ratzenberger, killed the previous day, challenged some of the assumptions that were being made in motor racing. Young men driving at 200 miles an hour in a circuit clearly is dangerous. Surely it's inevitable that some people die. Well, the cultural change which occurred when that idea was challenged following Senna's death led to an acceleration in safety in motor racing. Sadly, there's been one death in this decade, but from the 1990s till just 2 years ago, there have been no deaths in Formula One racing. Obviously, a whole lot of things were changed, a whole lot of factors were brought into consideration, but the most important one, and the point that I'm hopefully emphasising, is that it was about a cultural shift, a decision that really this was no longer acceptable. So I guess I would challenge you all in your areas of work to think about what is it that you assume is inevitably going to go wrong, and should it always go wrong? I'll come on to mental health. But before I come into mental health, I guess one of the things that predated the mental health programme here in Scotland, inspired it, and I guess essentially reinforced the government here in Scotland's view that this kind of approach to patient safety was the right one, was the success of the programme in the acute hospitals across Scotland. In the years prior to the launch of our national programme in mental health 4 years ago, there had been a challenge to the acute hospitals to reduce mortality. Clearly, acute hospitals deal with people who are medically ill and complex. Some will die. Are some of those deaths avoidable? Well, as the slide that you're looking at shows, 16.5% reduction in mortality in hospitals across Scotland over that period is thousands of lives saved. Obviously, this work was built upon work in the United States. The IHI model was one that was used. But it was this real success and success of this approach which prompted our mental health programme to be launched by the government 4 years ago. And so the programme in mental health sits alongside a number of others now. So here in Scotland, we've embraced the idea of improvement science applied to reducing harm in all the areas that you can see. And essentially, the overall aim being to improve the outcomes and make care safer for individuals in both health and social care services across Scotland. And the mental health contribution, or specific focus, has been around reducing restraint and violence, reducing the use of seclusion, something which service users told us when we started to look at where harm occurs in mental health. Being taken into a room because you're so disturbed that you cannot be managed with other people and left there may reduce the risk of you harming others, but it's not pleasant and it's maybe harmful. So reducing that, as well as reducing violence and self-harm, are the key things that we've been aiming to do. And I'm going to go in to tell you how we've gone about that and share some of the successes with you. So these are the 5 programmes currently, and patient safety, as I say, was launched 4 years ago and has focused on inpatient services across Scotland. So the first thing that we asked ourselves when we launched the programme was, well, we looked around the world to see where work was being done to reduce harm in mental health settings, and obviously there were examples, but not a huge literature. So we set about engaging with service users and carers and staff across Scotland in an initial 90-day programme, and the question we were asking was, well, is there something distinctive about harm in mental health settings? Reducing mortality, and the mortality associated with mental health services, I guess, is suicide, largely. Reducing that is a laudable aim, but that's actually a relatively rare event. What other kinds of harm would we wish to approach and deal with? So I'm now going to set a few examples, and we'll then have we'll be using a poll system to see what you think. And some of them might be obvious, but I guess this is designed just to prompt some thought. Oops, sorry, I should go back the way. So the first example, a female inpatient with severe depression under 50-minute observations managed to leave that inpatient ward and later found to have put herself into the local river and is drowned. So the first question, is this harm?
Thank you, Dr. Hall. So the poll is now launched for our participants to vote, and it's just the question is simple enough. So just 2 answer options, yes or no, and we have 40% of our audience who have already voted. So we'll just give it a couple of more seconds before we display the results. Okay, so I'm going to display the results now. And then for those who are not able to see, 88% of our participants think it is an example of harm, and 12% of our participants think that it's not. Over to you, Dr. Hall.
Okay, yeah, this raises the big questions. Is suicide a form of, I guess, I suspect most people would regard it as the most significant harm that we have to deal with or to try and reduce. I guess the next question, so I would certainly be on the side of harm, a suicide of anyone represents harm. The suicide of someone who's meant to be or who is receiving care in a hospital certainly is harm. I guess the next question is it preventable harm?
Thank
Should
you,
we be
Dr.
able to
Hall. So
prevent? Sorry, yeah.
we do have a second poll up. So our participants again just need to choose between two answer options, yes or no. And this time I was quick enough. So 72% of our audience has already voted. So we'll just give a couple of more seconds before we display the final results. And now we can see the results, and 95% of our participants think yes, it is preventable, and 6% think it's actually not. Over to you, Dr. Hall.
Okay, I guess, as I said, suicide clearly, I think, represents harm. There is more debate in the mental health community about how preventable suicide is. Some people are determined to commit suicide, and the argument is that perhaps even in any setting, that's very difficult to avoid. There is a zero suicide program, i.e. that suicide in people receiving mental health care should be down to zero, which is slightly controversial. I guess in this example, being under 15-minute observations in a ward, when we asked patients at the outset of our program where they thought they should feel safe, they said it was when they're in hospital. So that's why our program over the last 4 years has focused on inpatients in general adult psychiatric wards here in Scotland. So we would argue that, yes, inpatient suicide and people under observation should be largely preventable. And again, I'll describe to you ways in which we've gone about that. If I can bring up the next example. So a young man with a history of psychosis becoming increasingly agitated and demanding to be allowed out of the ward. He's restrained and giving IM medication. The restraint, i.e. the nurses hold him down, have to give him medication, takes place in the day room with a number of other patients present. Is this a form of harm?
Thank you, Dr. Hall. So we do have the next poll up. It's on a participant screen, and we would encourage our participant now to choose again between two answer options, yes or no. So do you think that scenario 2 is an example of harm? Then select yes, and if you think it wasn't, then please do select answer no. 44% of our participants have already voted, and we will just give them a couple more seconds before we display the results and see what they think. Okay, so we're going to share the results now with the rest of the audience. And 81%, very close to what we had last time. I think that scenario 2 is also example of harm, while 19% thinks that it's not. Over to you, Dr. Hall.
Yeah, again, when we spoke to patients and service users, they suggested that one of the most traumatic things that they experienced whilst in hospital. You could argue maybe it's necessary, but they would argue that being restrained is harmful, not necessarily in terms of necessarily the physical pain, but the psychological trauma, and indeed the issue of other people witnessing that. Witnessing a restraint taking place has a profound effect potentially on someone sitting in a ward where they think they should be feeling safe and looked after. So again, speaking to people who experienced restraint, they would tell you that it is a form of harm, and we'll go on to discuss maybe what type of harm that is. So the second question is it preventable? Thinking about the scenario, is this type of harm preventable then?
Thank you, Dr. Hall. So I actually launched the poll while you were commenting on scenario 2. So 56% of our participants have already voted. So it won't take long before we display the results. So I'll share the results now. And again, very close result to what we had for the question number 3, was it a harm event? And same number of participants, 81%, think, yeah, the scenario 2 is preventable, while 19% thinking that it's not. Over to you, Dr. Hall.
Yeah, thank you. Yes, I think when I talked earlier about the assumption that motivation is dangerous, one of the assumptions in inpatient mental health care is that very psychotic, very unwell people may well need to be, detained under the Mental Health Act, restrained, and given medication against their will. That's just something that happens. Again, I hope to be able to show you that, as people suggested, actually a lot of that is preventable because we've been doing work across Scotland, which has seen a dramatic reduction in restraint and use of IM medication. So again, it was a challenge, but I think people are now seeing this as a preventable type of harm. If I just go to the next example. Okay, the third example, a female psychiatric patient with a history of abuse finds that she's too anxious to leave her bedroom to sit in the mixed-sex TV room. Again, I don't know about the settings that people work in who are listening, but we tend to have mixed-sex wards, and this sort of scenario is something that's been described to me. Would this represent harm?
Thank you, Dr. Hall. The poll is now launched. Again, the same as with previous polls. Please do pick one of the answers, whether it's yes if you think that scenario 3 is an example of harm, and no if you think that scenario 3 isn't an example of harm. Our audience is quite active, so 50% of our participants have voted already, and this time it's harder for them to decide. So we will see what is the final result of the poll. So I'll just sharing the result, and we can see that 59% think that scenario 3 was an example of harm, and 41% thinking it wasn't. Over to you, Dr. Hall.
Okay, again, that's interesting. And again, it was perhaps a more subtle or controversial argument, but again, one that was put to me at the very beginning of the programme, a lady talking about her experience of feeling intimidated in a mixed gender setting. And the harm she certainly described was that it meant that she really didn't want to engage with the ward and got out of there as quickly as possible, despite the fact that she probably would have benefited from being there longer. So I think, yeah, it's again something which people would describe as harmful. Is it avoidable? Is it preventable? Is the next question, as you can imagine.
Thank you, Dr. Hall. So the poll is launched, and 50% of our participants have already voted. They do seem quite confident in terms what scenario 3 is, but we'll just wait a couple of more seconds before we display the final result. Okay, so I'll display the results now. And 80% again, so the final results is quite changed at the last minute. So 80% of our participants think yes, scenario 3 is preventable, and 20% of our participants think no, it's not. Over to you, Dr. Ho.
Yeah, well, again, I don't think I'll say much more, but I think I would argue it is harm. We have tried, not necessarily succeeded, to minimise. I think it's possible to eradicate that kind of issue unless you have single-sex wards, which we haven't got. So it remains a potential issue, and I'll talk maybe more about gender or sexual harm. A final example before we get into the rest of the presentation. A female patient, and again, it's a real life scenario, returns home after 2 weeks in a psychiatric hospital where she'd been detained, and a neighbour comments that it must have been very upsetting for the police to have taken her away. So does this represent a form of harm, do you think?
Thank you, Dr. Hall. So again, just 2 answer options, yes and no. And we will give an opportunity to our participants to vote before we display the results. Okay, so we will display the final results. And very similar to the previous one, 82% have voted yes, and 18% have actually chosen to vote no. Over to you, Dr. Hall.
Okay. Yeah, and again, I suppose what I'm trying to do, and hopefully succeeding, is challenging maybe people's ideas of what harm might be. That this is a more subtle social stigma, essentially, to go back home. And again, this is a real thing that patients talk about the stigma of being treated like criminals rather than people who need help. Inevitably, sometimes in rural areas, police do get involved in taking someone to hospital who's very ill, who doesn't want to go to hospital. Again, we've now become, through speaking to service users, patients, very conscious that this can be harmful. The final question, again, we'll just, for completeness, is it preventable?
Thank you, Dr. Hall. I think our participants are definitely more sure this time, so we'll give them a couple of more seconds before we display the results. And 94% of our participants think yes, scenario 4 is preventable, while 6 are still not convinced. So they have voted for, they have actually chosen no to answer that question. Over to you, Dr. Hall.
Okay, thank you. Just advance the slide, as you can see. I hope that was a useful exercise. I guess it was something that we spent a lot of time thinking about at the start of our patient safety programme. To reduce suicide, for instance, is clearly a laudable aim, but to focus purely on physical harm wouldn't have met the needs of the people that we're trying to serve. They told us very clearly, as the examples illustrate, that being in a ward, witnessing a restraint, being restrained, feeling frightened, psychologically harmed them, made them less likely to want to be there. Equally, stigma can be enhanced or made worse through how we get people in and out of hospital. So the social harm that can be caused by our intervention. So, taking someone to hospital to help them clearly may be necessary. How we go about that, what we leave them witness to, can cause psychological and social harm. And the whole sexual harm issue is, well, the example was of someone feeling intimidated because of their gender, but we also have occasional, thankfully rare, examples of people being actually abused in institutions, of course, which isn't just historical. It's something we should be wary of. And the manipulation of people who are vulnerable. Again, patients will tell or have spoken to me and said, I was very ill and I got involved in a relationship on the ward which I would never normally have got involved with. Please protect me when I'm manic and acting that way. So a starting point was to think more broadly about harm and what we were trying to do with our programme. So again, this slide just teases that out in a little more detail, with our overall aim of the 4-year programme thus far, which is now ongoing, a reduction in harm experienced by initially inpatients was the focus of our programme. And it led us to think about harm into these 2 broad categories. Category A, perhaps a more traditional, if you like, type of harm caused by medication or the interaction with the service, the actual physical harm caused by restraint, whereas the category B, on the right-hand side of the slide, harm caused by the behaviour of service users to themselves or others, self-harm, violence and aggression. So thinking about harm in these ways, as I've said, category A is just a broad subset just for the sake of discussion. We did, at the outset of the programme, look at, well, how common, how many incidents of this type of harm or potential harm are there? And this, I apologise, it's very old data, but it was the data that we were able to find at the time when we were first starting the programme. Over England and Wales, over a period in 2005, over 20,000 incidents which might cause harm being reported. And you can see the commonest in terms of absolute numbers of the harm caused by the service, essentially, where patient accidents and falls, medication errors being up there, and the severity of the level of harm indicated by the colour on the bar, most causing little or no harm, but some causing very significant harm, including death. And just to look at the amount of harm that we're seeing, or that we understand to be happening, thinking about category B harm, again, suicide, suicidal behaviour, self-harm, the largest, and again, over 20,000 or so incidents in the time of recording, again, historical, but we think this is representative of inpatient settings here in Scotland too. Disruptive aggressive behaviour being the commonest, self-harming behaviour including suicide being the next commonest, and death being a potential but relatively rare result. Most of the time these incidents resulting in little or no physical harm, although again, as we've just discussed, these slides probably don't reflect some of the psychological harm that people experience even witnessing aggressive incidents. So we've spent a bit of time, and we've got a little bit of time left, thinking about what harm is, the types of harm, and hopefully maybe challenging people's preconceptions about the harm that might be around, that might be avoidable or preventable. So these are our programme objectives, which hopefully you have time to read through. Working in a breakthrough collaborative across Scotland to try and engage with the health boards, which are the delivery units of mental health care here in Scotland, to test and implement interventions at a clinical level. Or, put more succinctly, we were aiming that patients and staff feel and are safe in our inpatient facilities. And I'll come on to mention where we're moving next. Or even more succinctly, Margaret, who's a colleague of mine down in Dumfries, summed it up just by saying, well, it's really about making sure people get looked after the way that you would want yourself or your relatives to be looked after, safely. So how did we go about it? Well, we had a bit of fun. We got people together. I'll give you some figures in a second, but we got people together in large numbers across Scotland. Learning sets, including that's Mr. Potato Head, that's not Jonathan, my colleague. That's a figure that we use in a little exercise, which some of you may have done to look at how you try and attain a certain degree of, you try and build a potato head in a certain way. How well can you do it? You measure how well you've done it. You do small tests of change. It introduces behavior improvement science to teams and lends a bit of fun. But more than having fun, we considered harm in other settings, perhaps, some of it pretty obvious, some of it clearly avoidable, and through that we got a level of engagement with the mental health community across Scotland, both service users, carers and staff. So the reason for the slide of the puppies is the one on the left is kind of where most Scottish people sit when it comes to anything new, i.e. they sit back and hesitate. Some people, however, like the puppy in the middle, dive straight in, and some and the one on the right make a bit of a mess of things, but that's allowed. And again, just a couple of pictures of some of the teams and some of the work that they've done over the last few years to look at harm and to look at how they might prevent it and to implement changes to try and improve the situation and make the service safer. So again, and I'm sure that many of you who are listening in know all about the model for improvement. Across Scotland, Health Improvement Scotland, which is where this programme sits, is an organisation which supports boards in trying to improve the quality and safety of their services. There are improvement advisors here and across Scotland who've linked up with frontline teams. But what we've done and what we've achieved is, I think, a cultural shift, in that this model for improvement, this idea that you should challenge the way you do things, identify something you want to change, have the freedom to try something different, have the freedom to make mistakes, but as long as you learn from them and identify a better way of doing things and measure that, then it's the basis of improvement. And similarly, it's the basis of improvement through a sequential approach, where a ward, and I'll give you some specific examples in a minute, might identify an area that they want to do differently, that they think they could do better. So they have a prediction or a theory, they test it, they implement a change, they go around the cycle of PDSA until they've identified the best way that they feel of doing that intervention in their system, and it becomes part of the routine operation. So 5-10 years ago, very little improvement science being used in Scottish mental health facilities. Now every ward you go to has a graph with a line chart on it. It has examples of things they've done. Again, I'm going to describe the level of engagement that we've seen. And I guess one of the things worth emphasising, and one of the challenges for people like myself who manages a service, is giving people the freedom to do things differently, to make mistakes. We're very worried about people making mistakes and then being blamed for it. A safety culture, as I'm sure you appreciate, is one where people have the permission to try things differently and to perhaps potentially make an error, but as long as they learn from it. So in terms of the overall structure or the broad areas of work that have been going on around Scotland, we at the outset, as a sort of central group, identified 5 potential areas of focus, one around safer medicines, one around risk assessment, safety planning, a key part of mental health care, identifying what risks there are and putting plans in place to try and manage those risks. Communication and transitions as a broad area of work, a work stream. And again, anyone who's looked at where failures of a system have occurred, often failure of communication has been a key part of that. And one that I've talked a bit about already, and one that the service users were very clear was an area that we needed to look at, was reducing the violence, reducing the use of restraint, reducing the use of seclusion. And the one that's centrally in terms of our work streams is the one around culture and leadership, because I guess without a change in culture, without the right leadership at all levels, then this kind of work just doesn't succeed, I think. So those have been the areas of work. And from those areas, over the 4 years of the programme, we've identified a number of overarching themes. And one that I'm pleased to say, again, which probably wasn't the case 5 years ago, was the need to look at your own data, to actually understand how often does a medicines error occur in our ward? How often did it happen last week? Can we do something to make it happen less often next week? So using data to drive improvement is something which is a key overarching factor, as are an attention to human factors. And the issue of human rights and legislation, which, given that in mental health we do force people to accept treatment that they don't want sometimes, we take away their rights, we have to have that on a legislative basis. So a human rights-based approach is something that we've worked very hard to achieve, and in fact there's some very important work going on in Scotland with the Mental Welfare Commission, which is our regulatory body, to look at ensuring that we've got a human rights-based approach to all our interventions. Education and training is, I guess, obvious, and perhaps the one that should be at the centre is that you can't achieve anything in this kind of work without engaging service users, staff, and carers. So from that, and what's in the middle, we've started to identify over 4 years a number of interventions that staff across Scotland have been trying out, which have resulted in improvement. What we term our key safety principles. So the scale, as you can see on the right-hand side of this slide, the scale of engagement is that we started with inpatient facilities, and there are 13 health boards across Scotland which have inpatient facilities, and they all wanted to be involved. That was great. People volunteered. Even some of the boards or health boards that didn't have any beds, like in the islands, said they wanted involved too, and they will now become involved. And every board has now got a large proportion of wards actively involved, giving us data about how much harm is occurring, giving us examples of what they're doing, sharing those with others, and we're now seeing improvements in every area of Scotland, or some examples of improvements in every area of Scotland around those work streams and those broad principles. So measurement, just a quick word about measurement. I'm not going to show you a graph like the one that you saw Professor Leach standing in front of towards the beginning of the programme with a 16.5% reduction in hospital mortality, because what we've emphasised is that the data that we ask our boards to collect, which they do and which they share with us, is for their own use primarily. It's data to drive improvement. We can and do believe that across the whole of Scotland we're seeing an improvement in the overall outcome measures, but more importantly we're seeing examples of considerable improvement in areas driven by their own work and driven by their own data for improvement. And we've highlighted that in mental health we're very conscious of, yes, counting things is important, quantitative data matters, but also qualitative data. Understanding the quality of what's happening and the quality of interaction is also important. So we have outcome measures, basically, broadly speaking, around levels of restraint, seclusion, violence, and self-harm. But we also, underlying those process measures, but also, importantly, I'll say a little more about how we measure the change in culture. Some of you, I'm sure, will be familiar with climate tools. They've existed to ask staff groups how safe they feel. Do they feel they could highlight a problem to a manager and be listened to? A series of questions which, taken as a snapshot, gives you an idea of how, what the culture of a ward, a unit, an organisation is. There was no such tool existed that we could find anyway for patients, so we developed one. And put at its most succinct, the best way to find out how safe patients feel in your facility is to ask them. So this is a structured, facilitated way of asking patients how safe they feel. And across Scotland, over 600 patients have completed this safety climate tool, which has given us rich, qualitative information about what matters to service users. And it forms part of, again, a cycle of improvement, feeding into identifying examples that can then be built upon to improve safety in that facility. And the participation of patients in this process is something which they fed back, makes them feel listened to in itself, and helps. So one of the things that we didn't do at the beginning of the programme, and we could have, because we had a lot of clever people in a room, people representing all parts of the services, identifying, well, where will we start? They could have come up with a list of things and said, if you do numbers 1 to 25, then your service will probably be safer. That probably wouldn't have worked as well, because that would have been somebody else's list being imposed upon the frontline services. Instead, what we have got and has been generated by these services, the teams involved in the programme across Scotland, are a number of interventions where they've tried themselves. For instance, work around medicines reconciliation, which occurs in many health settings, taken and adapted for mental health settings, used in different places, shared with others. Work around how risk assessments are carried out and how they're shared. Trialled, practiced, worked out in different ways, PDSA cycles in certain settings, and a way of doing that developed and shared. So what we've ended up with is a list. It's a list generated by the teams working on the improvements in their own areas. And that list is now, we are now producing these documents around the key safety principles, which are available, are becoming available in our website, and that's what the website is looking like, or is about to look like once completed. So just a few more minutes before I stop speaking, and I'll just take you, maybe to give you a more concrete example. And it's quite an old example, but it's the one that set me off in my interest in my journey, if that's the right word, into patient safety. It was done by my trainee, of course, it wasn't done by me, but we had moved into a nice new psychiatric intensive care unit, and we'd previously in the hospital had a suicide, and one of the things that came out of reviewing that suicide was that yes, risk assessments are fine, they're there, but they change quickly. If between a ward round on a Wednesday and a patient going home on a Friday, things might happen which influence the level of risk, and if that's not included in the risk assessment which the person making a decision on the Friday afternoon has, then things can go wrong. So we posed ourselves a challenge and said, well, we're running an intensive care unit. Surely our risk assessments about what risks our patients pose to themselves or others should be up to date every single day. Now, the response from staff was either, well, that's what happens already, or that's impossible. So from the top graph, you'll see that actually it wasn't happening already. Around about 20% of the time, in a slightly more complicated system, either in paper or an electronic system, the risk assessments were updated daily. Through a number of interventions, different ways of doing it, different ways of recording it, and using things like a safety huddle to share information on a daily basis with everyone, we, as you can see, over a period of less than 3 months, got to a reliable process where risk assessments were being updated daily in that ward, and not necessarily cause and effect, it did coincide with a reduction in key outcome measures, incidents of violence and incidents of restraint going down over the same period. So that's just one example of the kind of interventions which have been tried out across Scotland and then shared and spread, and that form part of our key safety principles. Another one which some people may have heard about, PRN medication, giving people a jag or a pill to calm them down, common practice, an assumption that this is a key part of what we have to do. Well, actually, using these stickers, which force identification of whether or not the PRN, the discretionary medication, has had an effect, has highlighted that often medication is given because that's what we think we need to do, but it doesn't necessarily have any great benefit. So it's resulted where people have used those stickers to highlight the use of PRN medication and people who are quite disturbed and distressed. But through greater compliance with that, not in the same area, we've seen a reduction in use of IM medication, a reduction in our outcome measures, improvement in physical violence, in this example in a ward up in the centre of Scotland. I'm not going to give you, as I say, overall aggregated data across Scotland, but more examples of the kind of improvements that people have seen. Workers in Forth Valley, and these are up-to-date figures, through interventions across the work streams, improving communication, improving risk assessment, changing the culture. We've seen a 70% reduction in self-harm in that facility. Up in the north of Scotland, almost 60% reduction in incidents of restraint through exactly the kind of process that I've described. And again, here's just an array of examples, and I'll put my hand up. I am picking out good examples, but I guess the good news is that across Scotland we have 7 facilities showing up to 75% reduction in self-harm. Across Scotland we have 9 facilities showing up to a 64% reduction in restraint. We have 15 facilities where violence has reduced by up to 80%. I highlighted that over 600 patients have used the Patient Safety Climate Tool. 3,000 staff have completed the Staff Climate Tool. People are engaged and things are happening. Where are we going next? Well, we were challenged at the beginning. Why are you starting with inpatient services? Most mental health care takes place outside hospital. Well, that was where patients thought we should start. That's where people should feel safe. We are now taking on the challenge of how this will work in community settings and also in other areas out with general adult psychiatry, child and adolescent psychiatry, older people's services and perinatal services for mothers and babies. And the really good news is that I'm talking about what's happened in Scotland, thanks to the great team of people around me and the services that are engaged. We are simply a reflection of other great work happening across the globe. Colleagues in South London, East London, Singapore, I won't mention all the places. There is now a genuine international movement which has identified that harm in mental health settings can and should be reduced. So it's great to be a small part of that. And as an international collaboration and a movement is an exciting thing to be part of. So as we move forward, if you're embarking on this kind of work, it has to be started small in your own area relevant to you, but don't be afraid to steal from others. Start with things that other people have done. Yes, take some clues from us, but make it personal, make it relevant to your own area. Be nice about it, challenge each other, but challenge in a nice way. Be brave. Allow your staff, if you're a manager, the leeway and the freedom to try and change things and accept that failures will occur, but you can learn from them. Cultural change takes time. We have seen, I think, massive cultural change in mental health in 4 years in Scotland. I'm excited about where that will lead us next. So, thank you. Yeah, and a final slide. Some people have not been in psychiatry for 30 years like I have, and they just see this kind of work as part of what happens, as opposed to something new. So I think that's a very positive message. And there's some contact details. Thank you.
Thank you, Dr. Hall, for this fantastic presentation. We do have a couple of questions, so I suppose we still have time to address them. And if our participants have any more questions, there's still time to type them in, and we will answer as many as we can. So the first question is from Akio Hirata from Japan. And And the question stands as follows. So how would you suggest, or how would you advise to begin or ignite the cultural shift amongst the staff? How would you start in the first place?
An excellent question. And I guess the reason I gave the example of the risk assessment daily updates was because that was where I started. I guess a bit like motor racing, it's a shame, but I think sometimes when bad things happen, it really prompts people to think. So Ayrton Senna died, and that really prompted people to think. My patient died, and I thought, we can do better. So it doesn't necessarily have to be something as dramatic or as bad as that, but I think when people identify even a small example of something going wrong, you can learn a lot from something going wrong or a near miss. So I think that's where a rich source of, well, let's just try and tackle that one thing. That person went home, the discharge medication wasn't with them, it led to a problem, they're readmitted within days, surely we can do something better about that. So if it's made relevant to something that's happened in that particular service, that is powerful. The second thing, the second example I would give is that patient stories. Speaking to, I never appreciated the impact of the whole gender issue until I spoke to a lady who had spent time in a psychiatric facility and who told me about how embarrassed and how difficult it had been when she came out. She realised some of the things that she'd been doing whilst ill, basically sexually disinhibited, and that we hadn't protected her adequately from that. So I think the consumer, the patient's view is key, and examples from your own practice where you think that could have gone wrong. So getting the word, we run an exercise where people are asked to identify what is important, what is the harm they're dealing with, and that's the starting point.
Thank you, Dr. Hall. So the next question is, what challenges have you experienced during the implementation of intervention as part of the Scottish National Programme? And in fact, how were they dealt with?
Okay. Well, again, at the very beginning, people who've worked in mental health may share this. Mental health services and some of the bad things that happened around institutionalisation and asylums meant that people of my generation worked in big hospitals, which became smaller hospitals. And we spent a lot of time persuading people that hospitals now are actually good places. So when I went along with a message to leaders in mental health around Scotland saying, actually, let's tackle harm that we're causing, there was an immediate, wait a minute, that's the wrong way to go about it. You're starting with a negative. You're telling us we're doing things wrong rather than saying lots of good work's happening. So there was a lesson there. So the challenge was balancing the message that there is avoidable harm caused to patients, not that people go to work planning to harm patients, but things happen that do cause harm and distress that are avoidable. Balancing that message with, yes, at the same time, we appreciate we're all trying to do a good job. So that getting the message right was a challenge. People always argue, of course, a second big challenge, if I can mention a second one, was resources. People are busy, we're trying to do a job of work. Do we have time for improvement science? Hence, making it relevant to their practice was key. But also, again, perhaps another example, putting resources and time into this work ultimately saves money and resources. Our own hospital instituted a hospital-wide huddle, everyone getting together in the morning to identify what the risks are across the hospital, sharing information about staffing levels, about key issues that were going on. It takes about 20 minutes, doesn't use a lot of resource. What it did do was allow for a sharing of staff, a reduction in staff being called in on bank, i.e. it saved money. So the challenges were about getting the message right and persuading people that it was something that they should invest in and that it would actually have dividends more than just improved safety. It would actually be more efficiency, more effective. I genuinely believe that safety and quality go hand in hand with efficiency.
Thank you, Dr. Hall. So the next question is from Navisa Idowu from Nigeria, and the question stands as follows. How effective is the method of tracking program over time?
How effective is the method of tracking the program over time? Mm-hmm. Yeah, in terms of, forgive me if I've not picked up the question correctly, but in terms of how we judge the effectiveness of the programme overall, the data, as I've emphasised, is really for the local services to use, and we certainly demonstrate to those who, our bosses, that the programme has been effective through having more and more examples of improvements happening. We have also subjected the programme to an analysis through a sociological tool, really, which highlighted what was one of the things in terms of understanding whether something's successful. What does success look like? It doesn't just look like fewer incidents of harm. It looks like a level of engagement, which I've described to you. It looks like certain outputs in terms of the key principles as being our main outputs. So in terms of tracking the programme, I suppose the greatest evidence I have that it continues to succeed, apart from the figures that I've shared with you, or some of them I've shared with you, has been that it's still getting funded on an ongoing basis because it's seen as being effective and valuable. So using data to drive improvement and data to demonstrate the success of something is two slightly different things, but I think we've achieved that. So again, hopefully that roughly answered your question.
Thank you, Dr. Hall. The next question is from Nazma Saeed, and the question stands as follows. What do you think of the IHI definition of harm, where some aspects are excluded, like psychological harm?
Well, again, that's a very good question. I do think we have deliberately argued for a broader definition. As I've said, that's based upon the experience of speaking to service users and staff about what they feel is important. So I think in mental health, I would actually argue in all settings that psychological harm probably should be included. I do appreciate that in terms of measurement and having something which is concrete and easier to measure, and there's a lot, that's an important part of measurement. Has to be something which is, you can consistently say that we're not comparing apples to pears. It's more difficult to be clear that what I call psychological harm is the same as what somebody else calls psychological harm. So the rationale for having a more tightly defined, narrow definition is that it allows comparison to be made more easily. But in terms of what is relevant to improvement work in a particular setting, I think you should expand the definition to include the harms that are relevant to the people in that system. So I would never argue with IHI, but I think for our purposes, I would suggest that we've adapted and appropriately adapted the definition.
Thank you so much, Dr. Hall. The next question is from Mohammed Al-Sabri, and he's thanking you for this excellent presentation. And his question is about the strategies for reducing harm. So would you be able to offer advice in terms of what strategies to use to reduce harm, especially with fall and medication errors in emergency room setting, where psychiatric patients are quite common?
Yes, that's a very good question. Again, the experience of service users in our A&E or emergency rooms can sometimes be very poor. And I guess our A&E departments, our emergency rooms would acknowledge that. And that's not to criticise them. These are busy places dealing with many types of, many presentations, and the acutely medically unwell who needs immediate attention obviously has to take priority over someone who's presented in psychiatric or psychological distress. I do think, and we have examples of what's going on in A&E departments to assist them in dealing with the person presenting with a psychiatric problem, in allowing them checklists or shortcuts, in allowing them greater access to specialist input. Although, again, one of the cultural issues about, and I'm probably giving you a more broad answer than you're looking for, but the cultural issue of, is dealing with psychological or psychiatric problems part of our job? Well, it's a common part of what happens in A&E. So persuading them, arguing, helping them understand that they're going to have to deal with this sort of stuff. It's not just somebody else's job, therefore you can't just push it away is the first step. So improving mental health responses or the responses to mental health problems in A&E settings is a challenge. Particular strategies are, I think, I go back to what I've said before, going into that team and saying, well, let's look at actually what happens. Where is there any potential harm? Is the fact that someone waits behind a curtain and then has an interview that other people can hear, is that causing them greater distress? Is there a simple mechanism to have the interview carried out somewhere else, etc.? So I think the starting point is, if it's an A&E or an emergency room department dealing with mental health issues, let's sit down and look at how things currently work. Let's identify where the current harm might occur. Let's pick one thing we can do better and use that improvement science method to try and change it. Again, probably a bit of a rambling answer, but I hope it's okay.
Thank you so much, Dr. Hall. And the next question is that how are you managing to sustain the cultural change that you have achieved? Would you be able to give any tips to our participants?
Sure. Well, again, built on our experience here, I think one of the most positive things has been the level of engagement of staff and service users. How you sustain that, and this is a real challenge for us because we are now taking our focus beyond the inpatient services. So I think what we did in terms of allowing people to generate their own safety principles, really, for them to come up with the ideas, and okay, we've brought them together and given a summary in these documents about here's where we think you should continue to work. What we've emphasized is that it's not just the work doesn't just stop in the inpatient side as we move our focus into other settings. So the way to sustain that is, yes, we've given them, guidance and support. We've asked them to keep measuring and keep an eye on their own data. It may move from measuring every episode of harm to measuring time between certain incidents, but we expect ongoing measurement to keep a bit of a focus on those areas. But that does come back to leadership, I would say, at the level where in an area say, well, we've done our best, we'll move on to something new. It's got to stay fresh, but you can't leave behind the areas you've already succeeded in. So a combination of leadership, ongoing refreshing the data, and keeping people included, because as we move into community settings in Scotland, all the work that's been done in inpatient settings has to continue, but we also have to include our inpatient staff who've pioneered that work and sharing it with the new teams. So keeping them, they've become teachers and mentors of others, and that hopefully keeps them going in terms of maintaining it in their day job.
Thank you, Dr. Hall. We will have to wrap up this session, and I would like to express huge thanks to you for delivering such a fantastic, very interactive and reflective webinar. So thank you so much for spending your time and sharing your expertise with us, and for delivering this excellent resource to our participants and sharing your information.
No, my pleasure. Thank you very much.
I would also like to thank our audience for attending the session and for their active participation. And goodbye for today.
Goodbye. Thank you.